Hey everybody, JT here from Dirty Bird, where training is continuous. Let me ask you a question. What if I told you a patient could bleed to death from a hole that's only a few millimeters wide? Would you believe me? Now, what if I told you that while trying to save them, you accidentally destroy the very thing keeping them alive? Well, that's the reality of dialysis access. As EMS providers, we're trained to recognize hemorrhage, we're trained to control bleeding, but very few of us are ever taught what makes a fistula different, why these patients can bleed so catastrophically, or how our routine interventions can accidentally cost them their last remaining access point. Today we're going to change that. We're going to talk about the physiology of kidney failure, the anatomy of dialysis access, why these hemorrhages happen, and most importantly, how to stop them using physics instead of brute force. Let's get into it. Dialysis access hemorrhage is one of the most intimidating bleeds we'll ever encounter in medicine. These patients can bleed to death in minutes. At the same time, if we don't recognize their access, we can accidentally destroy their lifeline while trying to help them. Our goal for you is to understand why these patients bleed, how to stop the bleeding effectively, and how to protect vascular access whenever possible. When you understand the physiology, the anatomy, and the physics behind a problem, the right treatment becomes much more obvious. So let's start with the first question. Why do people need dialysis in the first place? All right, so I want you to imagine you're dispatched for a severe bleeding emergency. You walk into the house. There's an older gentleman sitting in a chair. He's pale, he's weak, covered in blood. Blood is pooling on the floor beneath his arm. He's awake, but becoming increasingly lightheaded and telling you he doesn't think he's going to make it. Your partner immediately recognizes life-threatening hemorrhage, applies a tourniquet high on the arm. You begin getting the monitor together and getting vital signs while preparing for transport. Then someone says, that's his fistula. And it's not just any fistula, it's his last functioning fistula. He's already had multiple failed access points maybe, and this was the only one he had left for dialysis. Bleeding's controlled, the patient survives. You guys high-five each other, it's awesome. But now he may need a temporary dialysis catheter, another surgery. There's no guarantee another permanent access can be created sometimes. The story is not meant to make you afraid of using a tourniquet. It's meant to make you stop and think before you do. This is not just about stopping bleeding with these patients. It's about recognizing what we're looking at, understanding why these access sites are different, and knowing how to control hemorrhage while preserving the patient's lifeline whenever possible. And I want to be clear, if direct pressure isn't working, if the patient is exsanguinating, or a tourniquet is the only way to save their life, apply the damn tourniquet every single time. Bleeding philosophy is simple. Life over limb, right? Well, also patient life always comes before current vascular access. But if we can stop the hemorrhage with focused direct pressure, hemostatic gauze, or properly applied pressure dressing while preserving that access, we're not only saving their life today, we've also protected the treatment that will keep them alive tomorrow. And that's exactly what we're going to cover over these slides. So one, why the patient has dialysis access to begin with. Two, the importance of our assessments and how to treat these access points. Number three, how to explaining how the bleeding process is different and how things can worsen. And then finally, go through the different interventions we can do to stop the bleeding. So why are people on dialysis? The kidneys are far more than just the body's filters. They are one of the primary organs responsible for maintaining homeostasis. Every minute, they continuously filter the blood, removing metabolic waste products while carefully regulating electrolytes, acid-base balance, and total body water. The kidneys also have several important endocrine functions that are often overlooked. First, they help regulate blood pressure through the renin-angiotensin-aldosterone system, or the RAS. Right? When the kidneys sense that blood pressure or blood flow has dropped, they release this hormone called renin. Renin starts a cascade that ultimately produces angiotensin II. It's a vasoconstrictor that narrows blood vessels. And then they also send out aldosterone. It's a hormone that tells the kidneys to retain all the sodium and water. Together, these actions increase blood volume and blood pressure, helps us maintain perfusion to vital organs. Secondly, the kidneys also produce erythropoietin. It's often called EPO, and it's a hormone that travels to the bone marrow and stimulates the production of red blood cells. When kidney function declines, EPO production decreases, leading to fewer red blood cells and chronic anemia. It's very common in patients with renal failure to be anemic. That's another reason that, if you notice, dialysis patients usually appear chronically pale and fatigued. Finally, kidneys also activate vitamin D. Vitamin D that we get from the sunlight and our diet is not fully functional until it passes through the kidneys, where it's converted into its active form, calcitriol. Active vitamin D allows the intestines to absorb calcium efficiently, and it kind of helps maintain healthy bones. Without it, patients can even be at risk for hypocalcemia, bone disease, hyperparathyroidism, a bunch of things seen in chronic kidney disease patients. When the kidneys begin to fail, all of these normal physiologic processes, they start to break down. Waste products accumulate in the bloodstream because they're no longer being filtered. Potassium's a big one. Potassium can no longer get excreted, right, leading to progressive hyperkalemia. Hydrogen ions accumulate, produces metabolic acidosis. Water and sodium are retained, increasing intravascular volume, and predisposes the patients to pulmonary edema. Uremic toxins build up in the bloodstream, contributing to AMS, or altered mental status, encephalopathy, platelet dysfunction, multiple complications. Blood pressure regulation becomes impaired, red blood cell production fails, and bone health deteriorates even. So without some form of renal replacement therapy, these abnormalities continue to worsen until they become incompatible with life. For many patients, that therapy is hemodialysis. As EMS providers, there are 2 life-threatening complications of renal failure that should immediately move to the top of your differentials whenever we encounter a dialysis patient who's weak, short of breath, altered, critically ill, anything, right? First is going to be hyperkalemia. That can produce rapidly produce lethal cardiac dysrhythmias. And then the second will be pulmonary edema. Excess fluid overwhelms the lungs, impairs oxygenation. So if you remember nothing else from this section, just remember hyperkalemia kills the heart, pulmonary edema kills the lungs. There are 2 physiologic emergencies that we're most concerned about with these dialyzed patients. All right, so hyperkalemia. What normally happens? Every time your muscles contract, your nerves fire, your heart beats, potassium is moving in and out of the cells. Your kidneys are responsible for getting rid of the extra potassium that your body doesn't need. Think of potassium like electricity. You need the right amount. Too little, things don't work well. Too much, the electrical system is going to start to fail. What happens when the kidneys fail? If the kidneys stop filtering blood, they can't remove that excess potassium anymore. Every meal that you consume containing potassium, every cell that naturally dies, every normal body process continues adding potassium into the bloodstream, but nothing is taking it away. Eventually, potassium rises to dangerous levels. Now, the heart's electrical system is going to begin to malfunction. The heart runs on electricity. Potassium controls how cardiac cells reset after every beat. When potassium gets too high, the heart has to work harder and has a harder time resetting itself. At first, conduction will slow, then rhythms become wider. Eventually, the heart may stop responding to electrical impulses altogether, which will lead to lethal dysrhythmias, cardiac arrest. Patients like this will see weakness, fatigue, nausea, paresthesia, tingling, bradycardia. On the EKG, we'll see the wide QRS, the peak T waves, eventually the sine wave EKG, VFib, systole, right? Imagine a phone charger. The charger works because electricity flows at just the right voltage. Now imagine plugging that phone into a power line carrying thousands of volts. Too much electricity isn't going to make your iPhone work any better. It's going to destroy it. Hyper-K is kind of similar. Too much potassium overwhelms the electrical system. Let's move on to pulmonary edema. Okay, so pulmonary edema. What normally happens? Your kidneys regulate water. Every day they decide what fluid stays and what fluid goes. Drink too much water, you pee it out, right? What happens in kidney failure? If your kidneys stop working, the water has nowhere to go. Imagine continuously pouring water into a bucket without ever emptying it. Eventually the bucket overflows. The body becomes that overflowing bucket. Where's all the fluid go? It starts staying inside the blood vessels. As more fluid builds, blood volume increases. The heart has to push a larger volume of blood. Then pressure inside the pulmonary circulation rises, right? Eventually that pressure forces water through the walls of the tiny pulmonary capillaries and into our alveoli. Why can't they breathe? Well, the alveoli are supposed to contain air. Instead, they're filling with fluid. Now imagine trying to breathe through a sponge soaked in water. Trust me, it's not fun. Air has a hard time reaching the blood because the fluid creates this barrier. The patient isn't dying because they forgot how to breathe. They're drowning in their own body fluid. With those patients, we're going to see severe dyspnea, orthopnea, crackles, hypoxemia, sometimes that pink frothy sputum that we fear, often early hypertension. They're being diaphoretic and anxious. And obviously, they're going to have an increased work of breathing. Okay, so those renal patients, they need to get on hemodialysis or home dialysis. Not every dialysis patient's the same. Some come into a dialysis center 3 times a week, usually 4-hour treatments. Others perform dialysis themselves at home. Some do shorter treatments. Some dialyze overnight while sleeping. Bunch of different options that they have. Why does this matter to us? Because the access you're seeing tells part of their story. Now, we know that patients need access to their bloodstream to allow the blood to be cleaned by the machine, which is now acting as their kidneys. So we have the in-center hemodialysis, and we have the at-home. We have at-home hemodialysis, and the peritoneal dialysis. Today, we're only discussing the vascular access, but there are at some point, whether it's them or their partner trained, or maybe they have a dialysis nurse come throughout the week, they have their vessel access sites just like in-center patients. So we need to pay attention to what they have in their house as well. But there are different types, and usually it'll depend on the severity of the patient and ultimately to what they prefer. Okay, so we know why people need dialysis. Let's talk about the 3 ways they actually receive it. I want to make it simple. I don't care if you leave here remembering every surgical detail or if you can explain every step of how a vascular surgeon creates these. What I do care about is that when you walk into a patient's room, less than 3 seconds, you can recognize what you're looking at. Recognition will change your assessment. Recognition changes where you put your blood pressure cuff, where you start your lines, maybe even saves the only lifeline for that patient. But there are 3 access types we're going to discuss today. Dialysis catheter, an AV fistula, arteriovenous fistula, and an AV graft. So let's look at each one of these individually. Dialysis catheter. This one's usually the easiest to recognize. Dialysis catheter is essentially a large central venous catheter designed specifically for dialysis. You'll most commonly see them coming out of the upper chest near the jugular vein. Less commonly, you'll see them placed in the femoral vein. Unlike the fistulas and the grafts that we're going to discuss next, this access can be used immediately. There's no waiting period with these, like fistulas. No healing period, no maturation. If a patient needs dialysis today, this catheter can be inserted and used almost immediately. So why doesn't everyone just get one of these? They come with significant downfalls. They have the highest risk of infection by far. They have the highest risk of clotting as well. And they simply aren't designed to be long-term. Think of this as like a bridge that keeps a patient alive until something better is available. Now, when would we expect to see a patient have a dialysis catheter? Acute kidney injury, where dialysis has to start immediately. Maybe a patient who's waiting for a fistula to mature, or someone whose fistula or graft has failed and they need a temporary access point while another one's being created. So for us, using them, before we finish, I want to spend a few minutes talking about something that creates a lot of anxiety in EMS, and it's using hemodialysis catheters. If you've been in EMS for any length of time, you've probably heard someone say, never touch a catheter, right? Or a dialysis catheter. The reality is a little more nuanced than that. The question isn't whether these catheters can be used. The question is, when should they be used? How should they be used? And does your department or medical director allow you to use them? So let's start with that, what they are. Again, large bore central venous catheter used for dialysis, inserted typically in the internal jugular vein. These catheters are built for high blood flow. Big difference from other catheters. During dialysis, they routinely move hundreds of milliliters of blood every minute through the dialysis machine and back to the patient. You'll usually recognize them because they're much larger than other central venous catheters. Most have two large external lumens with red and blue clamps, one to remove blood from the patient, while the other returns filtered blood back to the circulation. I believe many are even labeled now with arterial and venous to help the dialysis staff identify which lumen performs which function. But here's the question everybody asks: should EMS ever use one? You can have some people with some hard nose out there, but I believe the answer is sometimes. If your local protocols and your medical directors allow it, a dialysis catheter can be an appropriate choice, whether it's when other vascular access is not available or obtaining alternative access would delay life-saving interventions. Examples might include cardiac arrest, severe hypotension, profound shock, or even extremely poor peripheral access for a patient where time is critical. However, these catheters should never become our first choice just because they're convenient. If we can establish a peripheral IV or IO, those options generally preferred because they preserve the catheter and reduce the risk of infection, contamination, damage. These are very important to these patients. If your protocol does allow you to access a dialysis catheter, sterility is absolutely critical. The catheter hub should be disinfected thoroughly according to your agency's policy before anything's connected. It's one of the most important steps. Another important thing is aspirating the catheter before flushing or administering any medications. Why? Because most dialysis catheters, if not all, are filled with a solution between the treatments to prevent clot formation. Depending on the center, it might be a heparin or a high concentration citrate solution. These locking solutions are intended to remain inside the catheter between sessions, not to be flushed into the patient's circulation. The general practice: aspirate, discard the locking solution before flushing the catheter with normal saline and then using it for patient care. After use, management of the catheter, including whether it should be relocked, it's all determined by local protocol and receiving facility. Another question is whether certain medications should or should not be given through a dialysis catheter. In general, if the catheter is being used as a central venous access and your protocols permit it, most medications are appropriate for central line. Can be used through a dialysis catheter. The greater concern is not really the medication itself, it's maintaining sterility, preventing any damage to the catheter itself, and preserving access for future dialysis. One thing I want you to recognize is not every catheter coming out of the patient's chest is a dialysis catheter. Right? Cancer patients have implanted ports, the portacaths. They sit beneath the skin and require special non-coring Huber needles to access. They should never be accessed with a standard IV catheter. Right? Some patients have PICC lines that enter through the upper arm and terminate in the central circulation. Others have Hickman or other catheters for long-term antibiotics, chemotherapy, even nutrition. These devices might look similar at first glance, but they serve different purposes. So make sure you know what you're doing. Dialysis catheters generally stand out. Again, they have those larger two oversized lumens with red and blue clamps, specifically for high blood flow. But the point is, recognize what you're looking at before you touch it. Just because it's a catheter doesn't mean it's the right catheter to use. And finally, I want to leave you with one important reminder. Everything we've discussed in this section is educational. Whether EMS providers are permitted to access dialysis catheters varies between states, agencies, and medical directors. Some systems encourage it under specific circumstances. Others prohibit it entirely. That means responsibility is twofold. First, understand what device it is that you're looking at and how it functions. And secondly, know your local protocols and practice within your scope, please. Not because I told you to. AV fistulas. Now, this is the gold standard. If you remember only one access point from today, I hope it's this one. And AV fistula is considered the best long-term dialysis access we have. A vascular surgeon surgically connects an artery directly to a nearby vein. At first, it doesn't really make much sense. Why would we connect a high-pressure artery to a low-pressure vein? Because the arteries carry blood under much higher pressure than veins, and that's what we need in order to kind of transform the vein. Once they're connected, that arterial pressure and blood flow begins changing the vein. Over the next several weeks to months, the vein starts adapting. It gets larger, thicker, the walls become stronger, eventually becomes durable enough to withstand thousands of needle punctures over the many years of dialysis. That's why patients typically have to wait, they have to wait before using a new fistula. It's not going to be ready day one. It has to mature. Personally, I think this is one of the coolest examples of vascular remodeling in medicine. The body literally transforms an ordinary vein into a durable access point of handling arterial blood flow and repeated cannulation. Now, because blood is moving so rapidly through this connection, there are two things you should expect to find during your assessment. First is a thrill. So that's the buzzing or the vibrating sensation you feel when you place your fingers over the fistula. I like feeling with my palm personally. I think you can notice the thrill a little easier when you hold hands over the site. And the second is bruit. That's the whooshing sound you hear with your stethoscope as blood's flowing through the access. It's the same thing we're listening for in the neck when we assess for atherosclerosis in the carotids. But a healthy fistula should have both bruit and thrill. You'll notice the look of them. There's those gnarly veins that people will have on their arms, kind of all bunched up, just looks real engorged. That's going to be your fistula. Okay, and finally we have graft, AV graft. So what happens if a patient doesn't have veins that are healthy enough to create a fistula? It happens often in these patients. Years of diabetes, maybe PVD, multiple previous fistulas, poor vein quality, overall. Sometimes the patient's own veins simply aren't good enough. Instead, surgeon, if they can't do a fistula, will create an AV graft. So rather than connecting an artery directly to a vein, they implant a synthetic tube beneath the skin. On one end of the tube, it's connected to an artery. The other end is connected to a vein. Blood flows through the graft instead of flowing directly through the patient's own vein. From the outside, a graft can look very similar to a fistula. You'll often see a raised area under the skin where the graft's located, and just like a fistula, it should usually have a palpable thrill and a bruit audible because the blood is flowing through it. However, usually you can tell by the horseshoe appearance that it's a graft, while usually a fistula is going to be that gnarly engorged vein that we were talking about. Because a graft is usually made from synthetic material, it doesn't last as long as a fistula, and it has a higher risk of infection and also a higher risk of clot formation. The trade-off is that the grafts usually don't require as much time before they can be used for dialysis after surgery. So if I had to summarize all three access points, I'd say catheter is the quickest, but it carries the highest risk. Fistula is the safest and most durable long-term access, and the graft fills the gap between those two when a patient's own blood vessels aren't suitable for a fistula. As EMS providers, our job isn't to decide which access patients should have. Our job is to recognize what they do have, protect it, and understand how it affects the care that we deliver. As EMS providers, one of our first priorities is obtaining vital signs and vascular access, usually. But before you place a blood pressure cuff or reach for an IV catheter, ask yourself a question. Does this patient have a dialysis access? A fistula or graft is much more than an enlarged blood vessel. It's a surgically created lifeline that may take months to mature and multiple surgeries to create. And it's vitally important for that patient to be able to clean their blood, right? So protect it. That means no blood pressure cuffs, no IVs, no routine blood draws from that extremity. Every unnecessary compression or needle stick increases the risk of thrombosis, bleeding, infection, or just overall failure long term. If you identify an access, feel for a thrill. That continuous vibration tells you blood is flowing through the fistula or the graft. There's a habit I'd like you to develop. Before you touch an arm, look at an arm. 5 seconds of assessment can save your patient months of additional procedures. One of the biggest mistakes in EMS is waiting for our patients to tell us they have kidney disease. They're not going to tell you everything. Don't wait. Just find it out yourself. Dialysis access is an assessment finding, just like JVD, cyanosis, pedal edema, anything. As you perform your primary assessment, quickly scan the chest, upper extremities. Look for dialysis catheters, fistulas, grafts, scars, any aneurysm, bruising, maybe fresh dialysis dressings as well. Feel for a thrill if you identify access. And then expand your assessment beyond the patient. Look around the room. Have situational awareness when you get into an atmosphere. Is there dialysis equipment? Is there a transportation schedule? Discharge paperwork from DaVita, right? Did family member mention that they missed dialysis yesterday? Finally, think about the physiology, right? Is our patient weak? Are they short of breath, fluid overloaded, bradycardic, showing signs of hyper-K? Always ask yourself, could this be a dialysis patient who missed treatment? The best EMS clinicians simply don't collect findings. They connect them. They recognize the access. They recognize the clues. And they let those findings guide us. They guide our assessments and our treatment. So why do dialysis accesses bleed so badly? Let's talk about why these bleeds can become life-threatening so quickly. If you haven't seen them before, they can get pretty hairy. The first thing to understand is that an AV fistula isn't really a vein anymore. Surgically, it started as a vein, but over time it changes because it's connected directly to an artery. It's exposed to much higher pressures and much higher blood flow than a normal vein was ever designed to handle. A normal vein is a low-pressure vessel. If you nick a vein while starting an IV, you usually see a slow, steady flow of dark blood. It's not under much pressure. A fistula is completely different. The artery is pumping directly into that vein. It's basically an artery. So the pressure inside is much closer to arterial pressure. Over time, that vein, as it gets bigger and stronger and larger, can handle repeated needle sticks for dialysis. But the problem is when that vessel is injured. You're no longer dealing with a simple venous bleed. You're dealing with a large vessel carrying high volume, high pressure blood flow. On top of that, many patients are already at an increased risk of bleeding. Some take anticoagulant medications. Others have platelet dysfunction caused by uremia, which means their platelets don't stick together well and form clots as effectively, even if their platelet count is normal. So now put all of those factors together: a large hole, a large vessel, high blood flow, high pressure, impaired clotting. That's when hemorrhages become catastrophic in a matter of minutes. Okay, pressure. This is where physics saves lives. Now we're going to talk about what I believe is probably the most important concept of this PowerPoint. The reason some providers struggle to stop dialysis access hemorrhages isn't because they aren't strong enough. It's because they're applying forces in the wrong place. The solution is not more strength. The solution is understanding the simple principle of physics. Pressure is calculated using a basic formula. As we see, pressure equals force divided by area. So let's break it down. Force, simply how hard you're pushing. Area, how much surface you're pushing with. Here's the important part. If the amount of force stays the same, but the area gets smaller, the pressure increases. Let's use an example. If you're applying 10 pounds of force and you spread those 10 pounds across your entire palm, that force is distributed over a large area, right? Each square centimeter of your hand is only applying a small amount of pressure. Now imagine using that same 10 pounds of force, but instead of your whole hand, you apply it with just a tip of your finger. Did the force change? No. You're still pushing with 10 pounds. The only thing that changed was the size of the area making contact with the skin. Because that area is much smaller, all 10 pounds are concentrated into one tiny spot, right? That creates drastically more pressure exactly where you need it. Imagine someone weighing 150 pounds is standing on your back while wearing a pair of tennis shoes. Probably wouldn't feel great, but imagine if that same 150 pound person is standing on your back wearing high heels. It's going to hurt a little more. Did they suddenly gain weight? No. The force is exactly the same. The only thing that changed was the size of the contact area. So instead of spreading all their weight across the entire sole of a shoe, all that force is now concentrated on a surface that's only a few square millimeters. So the pressure increases dramatically. That's exactly what's happening when we control a fistula hemorrhage. Our goal isn't to squeeze the entire arm. Our goal is to apply pressure directly over the hole where the blood is escaping. So if you use your entire palm, much of your force is wasted compressing healthy tissue around the injury. But if you identify the exact source of bleeding and apply focused pinpoint pressure directly over it, the pressure at that site increases significantly without requiring us to push any harder. That's why pinpoint pressure is so effective. It's not magic. It's not a special technique. It's simply physics working in our favor. So next time you're faced with a dialysis access hemorrhage, if you are, Remember this, don't think harder, think smarter. Find the hole, concentrate the pressure over that hole, and let physics do the rest. So here's one solution. This is the UK fistula cap, designed, basically it's a small rubber bottle cap, and the hollow side goes over that bleeding site. By decreasing the contact area, like we're talking about, they create a much greater pressure exactly where it's needed while minimizing compression of the rest of the fistula. Of course, most EMS units don't carry fistula caps, especially in the US. And the caps we have are not hard rubber, right, that size, so we can improvise. Think of objects that can focus pressure into a very small area. Tightly rolled piece of gauze, folded 4x4, a small wad of hemostatic gauze, etc. Even a bottle cap size object wrapped in gauze or incorporated into pressure dressing can act as focal pressure point for that site. The key is to avoid placing hard, sharp objects directly on the skin. Whatever you use, make sure it's padded enough to prevent tissue injury while concentrating enough pressure over the bleeding site. What I like to do, take that small EMS style quick clot that a lot of ambulances carry and apply firm pressure with that first, and then place something rigid on top of that, like a peroxide bottle cap or a sterile water bottle cap, top side down, and then apply pressure with a pressure bandage, like an Israeli, over the site. You can also use rolled gauze or whatever and tightly secure it down the object that you choose. Principle is always the same. Small contact area, great pressure. It's going to create better tamponade. If direct pressure alone isn't enough, or you need to maintain clot formation during transport, hemostatic gauze directly over the bleeding site. Again, that's what I like to start with. So this is why we're here today. Fatal dialysis access hemorrhage. Dialysis access hemorrhage isn't just something that looks dramatic. People die from these bleeds. The good news is that many of these deaths are preventable, and if they're recognized early and managed appropriately, of course. But there's three major reasons these hemorrhages become fatal. The first is complications involving the access itself. Over time, the fistulas and grafts are repeatedly cannulated, sometimes thousands of times throughout a patient's life. This repeated trauma can weaken the vessel wall. Some patients develop aneurysms or pseudoaneurysms where the vessels begin to bulge outward. I'm sure we've seen some big ones. I'm sure you have before. The skin covering these enlarged areas becomes thinner and thinner until eventually it may ulcerate or erode completely. At that point, it may only take a minor bump or spontaneous rupture for catastrophic bleeding to occur. The second involves patient-related factors. Many dialysis patients are prescribed anticoagulant medications, like we said, for other medication or medical conditions. In addition, kidney failure itself causes platelet dysfunction, making it harder for blood to clot effectively. And many of these patients are also elderly, medically fragile, so they have very little physiologic reserve. Blood loss that a younger, healthier person might tolerate could become life-threatening much quicker in this population. And the third category involves dialysis procedure itself. So during dialysis, two large needles connect the patient's access to a dialysis machine. If one of those needles becomes dislodged, or if the tubing disconnects, or if there's a failure at the connection between the patient and the machine, blood can escape pretty rapidly. Because the access is under high flow and pressure, a patient can lose a tremendous amount of blood in a very short amount of time. So if you work near a dialysis clinic, I'd just be ready. One of the most sobering facts is that many of these fatal hemorrhages don't happen in a hospital. They happen at home. Patient finishes dialysis, removes dressing, bumps their arm on a doorway, experiences a spontaneous rupture while they're alone. If no one recognizes what's happening, they may bleed to death before we even get there. So our job is to recognize the access, recognize the bleeding, and intervene before it becomes another preventable death. Okay, so this is a question everybody always asks. Should we ever use a tourniquet on a dialysis access? Answer is yes, when it's necessary. Our priority is still the same, life over limb, and in this case, life over access. A functioning fistula is incredibly valuable. Some patients have undergone multiple surgeries just to create that access. Losing it means more procedures, temporary catheters, higher infection, much more difficult road ahead for them. So If we can stop the bleeding with direct pressure, hemostatic gauze, a well-applied pressure dressing, some objects like I talked about, that's what we should do. We preserve the access while saving the patient's life. But there are situations where those measures fail. Bleeding is uncontrolled, patients becoming unstable. You can't maintain hemorrhage control. At that point, the conversation changes. We're no longer deciding how to save the fistula. We're deciding how to save the patient. A properly applied tourniquet will stop the bleeding from dialysis access. Properly applied. However, this is where people get in trouble. A poorly applied tourniquet, again, get those tourniquet skills up, practice it often, can make the bleeding worse sometimes because the veins collapse under lower pressure than the arteries. So if the tourniquet's too loose, it compresses the veins, preventing the blood from leaving the arm. But the arteries are still open, so the blood continues to flow into the extremity. Now we've trapped the blood in the arm while more blood is still arriving. Pressure inside, the access rises, and bleeding from the injury can actually become worse. That's why a loosely applied tourniquet is dangerous. Tourniquet should never be snug. It should never be pretty tight. Tourniquet's either working or it's not. When applied correctly, it completely occludes arterial blood flow. If arterial blood is still entering the arm, the tourniquet is not doing its job. So for pre-hospital, remember the sequence. First, use focused direct pressure. Add hemostatic gauze, put something rigid on it, secure it with a pressure dressing, continue reassessing. But if those interventions fail and the patient is facing exsanguination, don't hesitate. Apply the tourniquet correctly. Because at the end of the day, we can build another fistula. We cannot replace a patient. And that's the mindset I want every one of you to leave with today. Patient life always comes before a vascular access point. So let's bring this little talk all together. For a dialysis patient, vascular access is not just another piece of medical history. It is their lifeline. Without a functioning fistula, graft, or catheter, they don't receive dialysis. Without dialysis, the complications we discussed continue to worsen until it becomes life-threatening. That's why these access sites deserve our attention. As EMS providers, we need to recognize them, protect them, and understand how they change our assessment and our treatment. Remember that fistulas and grafts are high-flow, high-pressure vascular systems. They are not ordinary veins, and when they're injured, patients can lose a life-threatening amount of blood in just minutes. Fortunately, the treatment is not complicated. This is BLS. It's understanding the physiology and applying the principles of hemorrhage control correctly. So find the source of bleeding, create focused tamponade with pinpoint pressure, and let the physics work for you. If needed, reinforce the pressure with hemostatic gauze and a pressure dressing. And if those measures fail, or if the patient is exsanguinating, please do not hesitate. Just apply the tourniquet correctly. Patient life always comes before future vascular access. But if we can save the life and preserve access that keeps them alive tomorrow, that's the goal. The difference between a good clinician and a great clinician is not knowing more protocols. It's recognizing those subtle findings and understanding the underlying pathophys and making thoughtful decisions under pressure. All right. So thank you for spending your time with me today. I hope this helped you with how to stop a dialysis access hemorrhage if you ever come across it. I hope that it changed the way that you assess, or you will assess, every dialysis patient that you encounter in the future. And if this helps one provider recognize a fistula before placing a cuff, or stop a hemorrhage before it's fatal, or preserving a patient's last remaining dialysis access, then we've accomplished what we set out to do today. Until next time.